Good afternoon, everyone. I would like to thank the organizers for giving me this opportunity. So, staging laparotomy, one of the confused topics in gynecological cancers. So, it's been previously dealt in other malignancies also, like colorectal cancers and Hodgkin's lymphoma. But later on, with coming up of investigations like PET-CT and PET-MRI, in Hodgkin's lymphoma, staging laparotomy has been given away and routinely the non-invasive imaging studies has been followed. So I'd like to go on with the settings, introduction, and when to do staging laparotomy, why, how to do, and what are the recent advances and controversies. So when to do? So usually if a patient presents with an adnexal mass, we'll have some controversy whether it's benign or malignant, what to be done next. So as routinely we all of us know, we usually follow routine clinical examination like abdomen, vaginal, rectal examination to know where the mass is arising from. Apart from the assess for groin, axial and supraclavicular areas and lung, whether to rule out if there is any effusion, and breast, whether it's a metastatic disease or primary. Routine pelvic or abdominal ultrasound. Apart from that, we have latest imaging modalities like MRI, PET-CT and PET-MRI now. And apart from that, in ovarian cancers, we have an important role played by the blood investigation in the form of serum markers like CA125, HE4 antigen, and other markers like alpha-fetoprotein, beta-HCG, LDH, CEA, play a role in some malignancies if you have a suspicion, whether if it is not an epithelial ovarian cancer or if you are suspecting some germ cell tumors or other things. So routinely we follow up this with investigations and examination. And as all of us know, so usually 30% of ovarian cancers are early, that is usually stage 1 and stage 2, which need the role of staging laparotomy. And the importance in these malignancies is the stage of the disease plays a vital role in prognosis, apart from the grade, histological subtype, and quality of management, who is been doing the surgery and how far extensive the disease is been resected and properly staged. So why at all we do require a staging laparotomy? One thing is we need to remove the disease completely. So, and we need an accurate staging, because of the based on staging the prognosis varies, and sometimes the adjuvant treatment is based on the staging. And comparison from center to center, some may say I have done a good surgery, my results are far better than you. So other may say, no, I have done better surgery. So have a comparison, we need to have a proper procedure or technique to be done universally. And significant percentage, especially in ovarian cancers, may have extensive disease. Though they look like a small disease, sometimes they may have a extensive disease if they are not properly staged. And to have a better knowledge of the extent of the disease and improves proper staging laparotomy, improves quality and survival of an early ovarian cancer patients. And decision of adjuvant therapy is based on the stage of the disease. So ovarian malignancy, apart from other malignancies, has a specialty of being spread by transcoelom. So it can spread through coelomic layers with each of our respiration. Usually the flow of the peritoneal fluid, which runs in a clockwise direction. Similarly, the chances of the ovarian cells which are being spilled from the epithelium into the peritoneal cavity can move up along the right paracolic gutter into the right hemidiaphragm or surface of the liver onto left hemidiaphragm and left paracolic gutter, and sometimes into the mesentery. So it becomes important in these cases, especially because the ovarian malignancies have a specialty of transcoelomic spread apart from the routine lymphatic spread and hematogenous spread. Also it can spread to the surrounding organs like uterus, bladder and the rectum. So the ovarian malignancy takes a special page in a book of cancers in the mode of spread of the disease. So as all of us know, the stage 1 is confined to usually ovaries, and stage 2 to the pelvic organs, stage 3 beyond the pelvis, and stage 4 distant metastasis as per FIGO classification. So once you find a adnexal mass, we will try to rule out whether it is a benign or malignant. It's based on various factors like routine investigations like imaging along with some markers. A lot of algorithms have come like the RMI risk of malignancy index or ROMA. So we depending on these algorithms and markers, we decide whether we are treating a benign condition or malignant condition. Depending on that, we decide whether it requires extensive surgery or simple hysterectomy and removal of the ovarian tumor would suffice. So apart from that, we get a final pathology report. We decide upon whether it's a benign or a borderline tumor, or a malignant tumor. So depending on this, further treatment will be decided. So next I would discuss how do we do a staging laparotomy. Once you have done the investigation, examination, you feel it is looking like a malignancy based on the RMI or a marker, serum blood markers. So usually the position is supine, we take the position in supine position. And dorsal modified lithotomy position, especially if you are suspecting any involvement of a rectum. So sometimes you may go for a rectal resection or anti-resection. So the usual incision is longitudinal incision. We would like to go above the umbilicus. The incision is usually above the umbilicus because we need to have a complete thorough check of the whole of the abdominal cavity. And the disease is detected unexpected. If suppose you have opened then a transverse incision, we may need to convert into a J-shaped incision to have a proper exposure of all the organs. So first aim is to remove the tumor intact. So first you look for any free fluid in the pelvic cavity or in the peritoneum, in the abdomen. So if there is any fluid, you take the sample of the fluid. If there is no fluid is found, you give a wash in the pelvis and in the paracolic gutters and take the fluid for sampling. And you do a systematic exploration of the whole of the abdominal organs and viscera to look for any peritoneal deposits which could be missed in the routine investigation like CT or PET MRI. So usually follow a clockwise fashion. From cecum, you go along the paracolic gutter, ascending colon, right kidney, liver, gallbladder, undersurface of right hemidiaphragm, entrance of lesser sac at the para-aortic area, across the transverse colon, undersurface of the left hemidiaphragm, down the left colon, left paracolic gutter, rectosigmoid, and along the small bowel mesentery till the ligament of Treace, you go and observe all the structures, whether if I can find any small deposits which could be missed in imaging. So if no cross disease been found, you proceed with total abdominal hysterectomy with bilateral salpingo-oophorectomy. You take peritoneal washings from pelvic, paracolic gutters and subdiaphragmatic before the proper procedure. And we take pelvic biopsies from the pelvic side wall, peritoneum and around the bladder and along the Douglas pouch. You do proper intracolic omentectomy if no disease is found in the omentum. If active disease is found, you go for a total omentectomy. Bilateral pelvic lymph node dissection and para-aortic lymph node dissection. Look for any palpable lymph nodes and the appendicectomy is a little bit controversial. Some people routinely perform appendicectomy. In some cases, depending if the tumor is involved, definitely we go for it. Otherwise, performing of appendicectomy routine for all ovarian malignancies is a little bit questionable nowadays. So for the exposure of the retroperitoneal lymph nodes, we give incision along the origin of mesentery of the small bowel, rotate the bowel. From below the left renal limb, we try to remove all the fibropathy tissues in between the two ureters till the pelvis, including the pelvic lymph nodes also. So what are the results like by doing a staging laparotomy? So there is a systematic review and a meta-analysis which has been described in 2021 where nearly 23 studies is being evaluated and around 5,000 odd patients of stage 1 and stage 2 epithelial ovarian cancers have been taken. And they found around 18.7% there is an overall upstaging, and especially the upstaging is high in case of serous histology around 35.3%, and in high grade cancer it's around 40.9%. So it becomes important to do a proper staging because grossly appearing normal and imaging wise grossly appearing normal, we get up to a range of around 4 to 38% of cases we are able to see a higher disease or higher stage. So the tumor positivity is mostly found in cytology. Usually in cytology, 18.4%, though it appeared normal, they could find cancer cells in the cytological fluid analysis. So it becomes important to do a routine fluid analysis and proper staging to detect appropriate stage, and depending on that, the appropriate treatment can be done. So the lymph node involvement also varies depending on the stage of the malignancy. In stage 1, we usually have 15 to 25%, and stage 2, 20 to 40%, and stage 3, it's around 50 to 70%. I am speaking about both pelvic and para-aortic lymph nodes put together. And lymph node involvement usually depends on the grade of the tumor. If it's grade 1, usually 16%, and in grade 3, around 46% of patients can have a lymph node involvement. And para-aortic nodes are involved more frequently in case of early stage ovarian cancer in stage 1 and stage 2. The para-aortic nodes are involved, and pelvic lymph nodes around 15% of cases. Even the contralateral lymph nodes are involved, not only ipsilateral, the contralateral nodes also involved in 11% of cases. It brings the importance of having a proper, complete para-aortic lymph node dissection in early stage ovarian cancers because of the risk of metastasis to the para-aortic nodes. So what are the advances? Recently, we know not only they are not advances as such, so some conditions where we need to, whether we need to avoid a proper staging laparotomy. especially if you want to preserve fertility. Yes, around 5 to 7% of cases of ovarian malignancies can come in young age. So where we need to follow fertility preservation protocols or procedures. And in case of borderline ovarian tumor previously operated by someone else, where it is histologically confirmed that it is a borderline ovarian tumor, what to be done is, do we require proper complete restaging, or just a limited staging will be sufficient? So for a fertility preservation surgery, usually apart from peritoneal fluid cytology and peritoneum biopsies, ipsilateral, salpingo-oophorectomy is done. Usually contralateral tumors are not been, bilateral disease present becomes an option whether to go for fertility preservation or go for a complete staging procedure, because the cure of the disease is important rather than just preserving the fertility of the patient. So in these cases where fertility preservation is being done, around the relapse rate is around 4 to 17%, and relapse-free survival is around 70 to 63%, and 5-year survival is around 8 to 94%. And most of them had a good conception rates with no additional risk of having abortions or prematurity or congenital malformations. So borderline ovarian tumors where limiting staging is performed, because around 25 to 30% of intraoperative frozen analysis cannot show a borderline ovarian tumor. In these cases, limiting staging can be done. And even after doing limiting stage, sometimes we come out to find a peritoneal disease. So risk of lymph node metastasis is 5% in case of borderline ovarian tumor, especially in mucinous histology. So usual lymph node dissections are being avoided in case of borderline ovarian tumors. And the last, most often speak in most of the conferences or our teachings, it is the laparoscopic or minimally invasive surgical staging, which is coming in a big way. As all of us know, minimally invasive surgery will have less blood loss, less amount of hospital stay, people can go early to work, and less chance of having wound complications. Whereas staging laparoscopy is, what are the problems with it is, the risk of rupture may be high compared to open procedure, but some studies have shown there is no much difference in rupture risk, and lack of tensile tactile sensation may lead to loss of some detection of micrometastasis and increased operative time, but some studies have shown that both of them have the same operating time. A risk of port site metastasis is less than 1%. That's also risk been proposed by a few people, but the wound in metastatic rate is also around 2 to 3% in open procedure. So both of them come to a same range only. So completeness of occlusive staging question, because the number of lymph nodes dissected are less in case of laparoscopic procedure, but few surgeons who have good capability and good experience, they are able to do proper lymph node dissection. The nodes are relatively same. And early start of chemotherapy is possible in case of an laparoscopic procedure compared to the minimal invasive procedure compared to an open procedure. So overall, we would like to summarize this is surgical laparotomy is important to give a good survival to the patients, and preoperative decision may be required for few cases, whether I suppose in cases like Kurnool or local area where frozen section is not available, whether to go in stage one stage procedure or two-stage procedure becomes a questionable. And fertility preservation in young and laparoscopic minimally invasive surgery is a near future, is going to decide in most of the malignancies in coming future. And I would like to thank once again our organizers for giving me opportunity to have this presentation here. Thank you.
Thank you, Vaasu Reddy sir. It's a very elaborate presentation on staging laparotomy. You have nicely presented. Thank you.
Notes also involved in young perspectives. It brings the importance of having a proper complete paralytic lymph node dissection in early stage ovarian cancers because of the risk of metastasis to the paralytic nodes. So what are the advances? Recently we know not only they are not advanced as such, so some conditions where we need to whether we can need to avoid a proper staging laparotomy, especially if you want to preserve fertility. Yes, around 5 to 7% of cases of ovarian malignancies can come in young age. So where we need to follow fertility preservation protocols or procedures. And in case of borderline ovarian tumor previously operated by someone else, where it is histologically confirmed that it is a borderline ovarian tumor, what to be done is, do we require proper complete restaging, or just a limited staging will be sufficient? So for a fertility preservation surgery, usually apart from complete staging procedure, because the cure of the disease is important rather than just preserving the fertility of the patient. So in these cases where fertility preservation is being done, around the relapse rate is around 4 to 17%, and relapse-free survival is around 70 to 63%, and 5-year survival is around 8 to 94%. And most of them had a good conception rates with no additional risk of having abortions or prematurity or congenital malformations. So borderline ovarian tumors where limiting staging is performed, because around 25 to 30% of intraoperative frozen analysis cannot show a borderline ovarian tumor. In these cases, limiting staging can be done. And even after doing limiting stage, sometimes we come out to find a peritoneal disease. So risk of lymph node metastasis is 5% in case of borderline ovary tumor, especially in mucinous histology. So usual lymph node dissections are being avoided in case of borderline ovarian tumors. And the last, most often speak in most of the conferences are our teachings. It is the laparoscopic or minimally invasive surgical staging, which is coming in a big way. As all of us know, minimally invasive surgery will have less blood loss, less amount of hospital stay, people can go early to work, and less chance of having wound complications. Whereas staging laparoscopy is, what are the problems with it is the risk of rupture may be high compared to open procedure, but some studies have shown there is no much difference in rupture risk, and lack of tensile tactile sensation may lead to loss of some detection of micrometastasis and increased operative time, but some studies have shown that both of them have the same operating time. A risk of port site metastasis is less than 1%. That's also risk been proposed by a few people, but the wound in metastatic rate is also around 2 to 3% in open procedure. So both of them come to a same range only. So completeness of occlusive staging question, because the number of lymph nodes dissected are less in case of laparoscopic procedure, but few surgeons who have good capability and good experience, they are able to do proper lymph node dissection. The nodes are relatively same. And early start of chemotherapy is possible in case of an laparoscopic procedure compared to the minimal invasive procedure compared to an open procedure. So overall, we would like to summarize this is surgical laparotomy is important to give a good survival to the patients, and preoperative decision may be required for few cases, whether I suppose in cases like Karnool or local area where frozen section is not available, whether to go in stage one stage procedure or two-stage procedure becomes a questionable. And fertility preservation in young and laparoscopic minimally invasive surgery is a near future, is going to decide in most of the malignancies in coming future. And I would like to thank once again our organizers for giving me opportunity to have this presentation here. Thank you.
Thank you, Vaasu Reddy sir. It's a very elaborate presentation on staging laparotomy. You have nicely presented. Thank you.